So, and just kind of to explain, all of the parts of the study, it's a 40-week trial, so it tells you how long. You can also kind of use that data to kind of say into your patients, it took 40 weeks to achieve this type of weight loss, because a lot of people, like Kim Kardashian or whatever, I don't really know that she's on Ozempic, but that's the rumor, lost like 60 pounds or something. But she also has a personal trainer, a professional stuff, all chef, all this stuff. She's not your average person making their own food, eating whatever. So these are, again, clinical trials, 12,000 or 1,200 patients. That's a decent clinical trial. It's not huge, especially given the common, like diabetes is really common. But anyway, just kind of consider those. Okay, 40 weeks. This is what we're looking at. So this is where I shifted my mind in a clinical setting, because I used to be like anti-Ozempic because I was like, oh, people are abusing it, whatever. When I saw these numbers in real patients that I worked with Dr. Patel's office, this is when I started to become a fan of this, because it's very effective. It's relatively safe. Are these numbers right here? I mean, a 1.4% drop in A1C on the starting, some literature will say 0.25 is the starting dose for Ozempic. Some, this is maybe considered the midline dose, but either way, you could start, someone who already is diabetic, you could probably start on 0.5. That's significant in A1C. 1.4, that's, 7 to 5.6. Like, that's a huge drop. That person would be no longer considered diabetic. Or they'd be medication controlled diabetes, obviously, because the medication is what's doing that. And then on the larger dose, 1.6. So one thing I appreciate about these charts is that they didn't show the 2 milligram. We have not really seen, and I've also seen it clinically, that the increase in 1 milligram to 2 milligram, which is the next jump, isn't as effective as like a 0.5 to 1. And with 2, you typically get like double the side effects. So 1 is kind of the money point. It's kind of diminishing returns once you get on 2. Not for every patient, but many patients complain of so many side effects GI wise that they decrease it back down. And then you see, I thought these were just great graphics. The weight loss, 10 pounds, 12, 13 pounds. And these are in, obviously, I don't know how tall these people are. I don't know what they're, what their starting weight, but I would like to lose 13 pounds. So that's significant. That's a good amount of weight loss. And then, we could potentially, if they have blood pressure problems, and you're thinking comorbidities, when you're thinking about people with diabetes, there's all these things we have to consider. Losing 13 pounds could be decreasing their blood pressure by 5 to 10 points or whatever. So that's significant. And then this is the same. This is butyrin. Now, I did not see very many patients on this. Maybe it was just, every doctor kind of, you get into your rhythms and your prescribing habits and things like that. I didn't see a bunch of patients on this, but we see the Ozempic. And again, this is the higher dose compared to the higher dose. So they're comparing like titrations basically, and we're seeing more weight loss. Again, here, Januvia, this is a really common one. We see the differences. A 1.5% A1C loss, like that's a big deal. And these are great drugs to start on patients who have like A1Cs of 12 or 13, because metformin, you might lose by 1. Glipizide, the average A1C loss is like 0.4. The glitazones, the average A1C loss is like 0.4 to 0.7. So if you need like numeric, like big chunks of A1C decrease, a semaglutide, a GLP-1 is a great place to start, because the highest I saw in the data of patients, because I looked at Dr. Patel's data, was 2.3% loss. Like, that's massive. Again, you see the weight loss is just more effective than other things in its class. Same here with Lantus. So Lantus obviously is insulin, if you didn't know that. So the starting A1C, you see it's more effective than insulin, because it's targeting more spots. And then obviously the biggest downfall, sorry, my voice is getting dry, with Lantus is weight gain. Nobody wants to gain weight. Well, most people don't, but yeah. So also, I didn't mention this before, someone who is underweight is not a candidate for a semaglutide, because we know that their main side effect is A1C lowering, or not side effect, but purpose, and also weight loss. So if you have a patient who's underweight, semaglutides would not be a class you'd want to do. So this is, I think, my last slide. When you're counseling the patient, at the beginning, GI symptoms last 2 to 4 weeks. So eating small meals, eating slowly, that's your way to go. And you also, it's an appetite suppressant. So eating, if you're a 3 meal a day and 2 snacks, maybe you go down to 2 meals a day. And by default, if that meal is small, especially if it's smaller than what you're used to, you're going to be in a calorie deficit. Keep unopened pins refrigerated. And then of course it is a needle. It's very, very, very small. It's the same needle as like the insulin pen. But obviously safe needle practice, clean it, etc. So that is all I have. Any questions? What is the most important information should a person know about Ozempic for diabetes? That's a good question, Austin. I would say obviously the most common reason people come off of Ozempic is GI side effects. That's typically resolved in 2 to 4 weeks. But if your patient doesn't know that, if you don't counsel them appropriately, that can be something that they're not going to do it. And then once a patient decides they're not going to do it, it's really hard to convince them otherwise, because you should have counseled them on that information before. Also, it needs prior authorization for most insurances. I tried not to get into this because I wanted to keep it more medical, like kind of from like a pathology and physiology standpoint. But obviously we have to consider these things when we're providers. A lot of Ozempic right now, a lot of insurances need prior authorization. So if a patient can't pay for it, what is your backup to treat their diabetes? Yeah. Honestly, their website was really good. And I thought that they're like, just Google Ozempic, and it's like the first one that shows up. Of course it's geared to make you want to take Ozempic because it's their website. But I did find that their studies were pretty comprehensive. Their 40 weeks or 52 weeks trials, which over 1,000 participants of people with pre-existing diabetes. So that I feel like encompasses a fair number of people. You could do, I mainly stuck to that. I talked to my actual provider that I was with, my family, Dr. Patel, who was prescribing it, and asked him kind of why he shifted to that. And his main reasons were, it's effective, it's relatively safe, it's once a week. So all people have to do, remember, is once a week. People generally like the kind of weight loss thing. So yeah.
Hey, Jansen, it's Adele on SGA. So I don't know if you know this, but do you know the exact or the guesstimate or estimate of the incidence of pancreatitis that has occurred? Since it is so unknown, I was just curious.
Yeah, I don't know the exact number, like on the percentage of patients that were having that. Obviously pancreatitis is like a really intense thing. So people end up hospitalized and it's well followed, and then you're pulled from the study or you're pulled off of it and that incidence is reported. I don't have a number. That's one of the more severe side effects. Of course, anything that acts on the pancreas, you have to be very aware of. But no, I don't know the data on the percent. I just know it's like if you've had a history of pancreatitis, that's an absolute contraindication up there with like the cancer stuff.
Okay, that's good to know. I just think the benefits truly outweigh the risks in this medication. So
Right,
thank you for
right.
providing so much
Yeah.
information on it. It was great.
And another thing to consider, like a lot of diabetic medications have pancreatitis as a side effect, like metformin, that has a pancreatitic risk. Hydrochlorothiazide, which is a blood pressure medication, but oftentimes you have to control the blood pressure a little bit more tightly in a diabetic, these comorbidities. And so obviously something to consider, something to be aware of your patient's history, something to ask about. But I agree, it's always a risk versus benefit situation when prescribing.
Perfect. That you did great. Thank you.
You're welcome.
All right, perfect, Jansen. I think that's all the questions we have for right now. Thank you so much for doing this presentation for Lunch Club.
You're welcome.
Yeah, especially nowadays
All
with
right,
like
y'all have a good day.
TikTok. Yeah. Oh, give me 1 second. Yeah, just because of all the fast information on TikTok or Twitter or what is it, X now, that it's nice to get back to the whole evidence and all the facts and whatnot.
Right. Yeah, I was super skewed and super like anti kind of against it because I didn't understand how of an effective diabetic medication it truly is. I was only seeing like kind of the weight loss, like people who wanted to try it and I have a friend who has lost a lot of weight on it and that was her goal. And I'm like, okay, well, it worked. So
yeah, as long as it works, I guess, for some people. All right. Well, thank you for joining us today, Jansen.
Yeah.